This is the Authority Company Podcast, conversations with leaders that are designing our future. Hola, I'm Joe Pardavila, and we all know that the healthcare system in America is not perfect. And many believe that there are ways to fix it, including my guest. His name is Dr. Marschall Runge. He is the author of the new book, The Great Healthcare Disruption, Big Tech, Bold Policy, and the Future of American Medicine. Dr. Runge is the Dean of the Medical School at the University of Michigan, and he has big ideas, and I can't wait to get into. We're going to talk about the current state of healthcare. We're going to get into those Ozempic drugs that people are talking about and what we can do to fix healthcare in America. Dr. Runge, welcome to the podcast. How are you?
I'm great, Joe. Thank you very much. Looking forward to speaking with you.
Oh, me too, Doc. And, it's funny because, looking back about a year ago, you announced you were stepping down as the head of Michigan Medicine, and you're getting very close to that date. I hate to start with something so deep, but any second thoughts about that retirement that you discussed? Not that you're going, we're putting it out to pasture, and we're going to talk about it. You are going to continue working in medicine, but you're stepping down as your role as a leader there.
That's right, Joe. The end of June. And this is in part because Michigan has a general guideline that deans serve 2 5-year terms, and part of my job is as dean of the medical school. And when I started, I thought, wow, I don't know if that's going to be enough. And I was offered to continue for another couple of years if I wanted to, and I decided it's time. So I have really tremendously enjoyed the privilege of these roles at Michigan. But I think also I understand the 10 years and it's time to get some fresh blood and fresh thought. These will be challenging years in medicine. So I look forward to those who will replace me.
That's awesome. Awesome. Well, good. I'm glad you're no second thoughts or anything.
No,
Start the conversation.
I'm 70 years old, married for 45 years. We have grandchildren. As my wife often reminds me, these are years that we ought to enjoy life. So we will.
Good for you. Good for you. So I want to get started with the subject of physician leadership, because I have a lot of physicians in my life, not family members, because we're always a bunch of regular. We're not smart people like you guys. But one thing I'm fascinated by is the idea of physician leadership, because I think sometimes there is that fine line of like, it's automatically assumed a physician is a leader, but then all of a sudden, then you have the extra layer of actually being an actual leader, like the many positions you've held of being the boss of departments or schools or what have you. And I'm curious, I was thinking about this morning. In sports, I don't know if you've heard of this analogy, the great athlete is usually not the great manager or coach. Like there's very few like all-time great athletes that transition to become all-time great coaches or managers. Is that the same in medicine, where like the uber, the best of the best doctors don't always make the great leaders? And the argument is that usually that sometimes these great like athletes, they can't relate to the scrappy last guy on the bench or the 25th man in baseball. And so there's that difficulty there. But tell me about how the great physician can also become a great physician leader.
Well, I'll start off by saying that today there are more physician leaders than there were when I started my career. There are very few physician leaders. I think that's a good thing. And because if you're somebody who's been in healthcare, you've seen patients, I continue to see patients, it just gives you a different perspective than somebody who really has never had that personal experience. Not that there are not lots of great leaders who are not physicians or not healthcare providers. But it is the minority of people who are physicians who go on to be, outstanding leaders. And I think there are a couple of reasons for that. One is that people who are great clinicians, and I've had the chance to work with many over my career, that's what they love to do. And most times they don't want to go on and do something that's more administrative, that's going to take them away from patients. And likewise with people that are great researchers, many of them don't really want to go on and become leaders because they love the research they're doing. I've got a great friend who we were residents together. He's both a great clinician, and he then devoted his career to research and won the Nobel Prize. Does he want to go be a big thing in academic medicine or run a scientific institute? He has no interest in that, which is, I think, is great. And just to give you a little bit of perspective on my career, when I was, when I really got started after all of my training, I didn't have big goals of being in a leadership position. In fact, I thought after my first 3 or 4 years that perhaps if I became head of a cardiology division, that would be, I didn't aspire for anything more than that, and maybe not that. And what happened to me over my career is I typically, and this happened 3 or 4 times, either somebody had left and there was a need for somebody to do some part of leadership, or in almost all my positions, I wasn't really looking for change, but people approached me, and then I'd look at a couple of positions and decide, well, maybe that would be an interesting thing to do. So that's been my career. I absolutely never ever would have aspired to or even wanted to be a dean or a CEO of a health system.
Wow, that's great. Thank you for sharing that. And it's funny too. The one thing that's a recurring theme with doctors, and I guess when we become an administrator, it's all of it. But the paperwork part of being a physician, that is the one thing that you hear constantly from doctors. It's like, they'll throw out stats like I spend 70% of paperwork and then 30% with actual patients. The numbers all change there. But and I know a couple of years ago they tried the EMR, EHR, the electronic health records to ease things. It turned out that wasn't the cure all of it all.
Right.
And I know a big part of the next phase of your life is going to be like, revolutionizing healthcare. What can be done in that space? Because I feel like there's so many hours taken away from these talented physicians and clinicians that could be done with actual patients, but they're spending so much time with paperwork. What kind of fix do you see there, sir?
Well, I think there are some fixes that can be really important. And I think the biggest ones are going to be AI enabled. So I'll give you an example. 15 years ago, when electronic medical records really became the standard in health systems and in private practices, what I heard from all my friends and all my colleagues, and my wife, who was a dermatologist, was that this is ridiculous because I'd be finished. They'd say, I'm finished with my day when I finish seeing patients at 5 or 6 or 4, whenever that is. And that was the way it used to be. They didn't have any more notes to catch up on, but there was a phenomenon that filling out these notes for electronic medical records took a long time. And really the average for a busy clinician is about 2 extra hours a day. Unbelievable. And
Wow.
I know my wife, she's, as I said, she was a dermatologist. Used to come home at 4:30 or 5 and be done. And toward the end of her career, we were at UNC when UNC had fully implemented Epic, which is one of the big medical records. She was spending a couple of hours every night. And so when we moved to Michigan, she was like, do I really want to continue doing that? And that's a very common experience. And so I'll tell you about one AI enabled uh, reality today, and that is what's called ambient AI. And there's a physician is with a patient, and their entire conversation is captured. And it's not just transcribed, it is converted with the magic of AI, which I can't explain to you, into a really great note for that visit. And it's even better than what a doctor might put together, what I would put together. I haven't used this system yet, but I've seen demos and I've talked to a lot of people that are using it. We're using it here in Ann Arbor. We're starting to use it broadly. One of our partner hospitals in Grand Rapids has been using it. They were the first adopter in the state of Michigan. Uh, and what it does is uh, quite amazing. So first of all, I don't know the last time you went to see a doctor. I have a great internist. He's a fantastic guy. But when I go to see him, he's not looking at me. We're having a conversation, but he's typing
On the
in his
screen.
computer.
Yeah.
And that's one of the approaches people have used. Now he's still not done. He's going to have more to do later that day. Uh, now I interact with somebody who's using ambient AI, and it's just like having the conversation we're having back and forth. And they don't have to take any notes. No writing down things for reminder. And the notes that come out, they're better than what I would produce, because what I produce, and I don't know if you've ever looked at your own medical records, but your medical records consist of what your latest visit is, plus all the other junk that's happened over the last 2 or 3 years. And it's hard to plow through that if you're a physician or a patient. Uh, Ambient AI summarizes all that. And in fact, AI is really good at summarizing what may be a 50-page electronic medical record into 2 or 3 pages. And so that's an example. Other things that doctors have to do that I think is a total waste of time, which came in with electronic health records, was all the billing and coding. We're not taught to be billers or coders. And I found that really frustrating. And then, of course, we get feedback which says you missed this code or that code. And so AI is really good at billing and coding. And in fact, before health systems started adopting AI around what's called the revenue cycle, the insurance companies were on this a long time ago. And so we send in a request for payment, a bill, and they use AI to screen the record. They have 20, 50 criteria they're looking for that should have been documented. And in a minute, they find out if they've all been documented. And ultimately, they haven't. But instead of having a person to read through all that and sometimes make mistakes, and then send it back to the providers and say, well, you didn't do this, you didn't do that. It takes no time at all. We get this thing back that is incredibly frustrating. So I believe that in the very near future, health systems will adapt to using AI. Now it'll be, instead of a doctor arguing with a coder at the insurance company, it's going to be AI arguing with AI. And at the end of the day, I think it'll be fair.
Yeah. And that leads us to the book, The Great Healthcare Disruption. And as you know, Doc, you are one industry, and I think most, but you're the one that, like, we don't like disruption. I mean, the EHR we've been talking about the last 10 minutes, that was a big disruptor and no one liked it. And it's taken years and years and years to essentially perfect it. Now, we talked about the fact that this is a point in your life where you kind of want to slow things down. You're not going to run the medical school, but you still want to help the next generation. Why was this the right time for you to write this book?
It was a great time to write the book for several reasons. The first is that Forbes has a great brand. So I knew that if I worked with Forbes, they'd approached me, that it would be something more than an academic exercise. And we all publish papers, and a few people read those papers, and a huge amount of work goes into them. And this was a large amount of work as well. But the Forbes team was great to work with, and I know that it'll get some visibility. The second was that it was really a tabula rasa. I could choose the topics I wanted to talk about. And so I was able to choose topics that I thought were very controversial. And I'll give you one that sort of is a continuation of what our discussion about medical records and about patient visits. So I will ask you just a question. If you need to go see your primary care doctor or any other doctor, do you have trouble getting an appointment that fits your schedule in a short period of time?
Hell yeah.
I was going to say, if you said no, I'd say, I want to live where you live.
No. HELL. Yeah. Hell yes. I think most people can relate to that.
I like that, Joe. And it is a really a problem. So that is, I would say, for Michigan medicine, that is our biggest problem, is access. And it's frustrating to doctors. It's frustrating to the nurses who try to triage it. It's very frustrating for patients. And some of that is not having enough providers, not having enough doctors, nurses, et cetera. But some of it is just the way these systems work. So if you were to call and say, hey, I want to see an internist or a family medicine doctor at Michigan Medicine, I've moved to the area, I want a complete checkup, he'd be looking at 6 months, maybe 2 or 3 months.
Wow.
And the reason is because we use human systems, and we say, well, the person who's trying to schedule for you say, well, do you have a doctor preference? And you might say, yes, I want to see Dr. Jones. Do you have particular health problems? Do you have this and that? It's a long list of things. And then they try to put you in the perfect clinic. On the other hand, if you say, golly, I'm not going to wait 3 months, they say, well, how about Dr. Smith? Dr. Smith has an opening next week, but doesn't usually specialize in hypertension or whatever the issue is. But even that's too long. And so one thing we're doing is to use AI to try to improve that scheduling process. I also spend a fair amount of time talking in the book about the dearth of primary care in the United States. So if you look at our healthcare system, um, our healthcare system is by a long shot the most expensive in the world and the most expensive of peer countries. I'll call, highly developed countries. We're off the scale in terms of expense. If you read the book, you'll see in chapter 2 that if you look at how much primary care access they have a lot more than we do. So we need to train more primary care physicians, and that's been a problem for years. We need to train more physicians in general. U.S. specializes in accreditation and I'll just call it a lot of process that is mostly meaningless in order to achieve our goals. So that's a big issue. But so what has that resulted in? Well, that's resulted in lots and lots of new entrants into healthcare. So take one that's well known. So Amazon has a clinic now, and I hear good things about it. You can call night or day, 24/7. You'll probably get to talk to a doctor, although you may not. You may talk to another healthcare provider. You might even start by talking to a pretty sophisticated bot. But you get access. Like you wake up tonight and you can't breathe, you can call them. And we need that kind of access so that people don't go to emergency rooms, because emergency rooms are both packed, expensive, and may not be the best place to get the kind of healthcare you need. So all these companies are popping up. They're 30 or 40, none as well known as Amazon. And in fact, I gave a talk yesterday at a national IT meeting. It was fun because all these technology experts were there. They didn't know a lot about healthcare, but I gave an example, a slide that showed 90 different entrants into healthcare.
Wow.
So all that's good. But now let's come back to interoperability and connectability. So if you called up one of these places last night, there would be virtually no way for them to know all your medical record. It might turn out that you had forgotten that you're on a certain medication that wouldn't interact with them at all, that would interact with the medication they're prescribing to you, or that you have an allergy, or that you've had a bad reaction. The provider wouldn't necessarily know that unless you know your medical record perfectly. But more importantly, next time you go see your primary care provider, they wouldn't have access to that record. And so I think until we solve this problem of interoperability, those companies provide a service, but it needs to be recognized that they provide, that's an encapsulated visit. And if you call back Amazon the next time, you won't talk to the same doctor you talked to the first time. And so it's a very different approach to healthcare. Now, I will say that in the United States, people want that kind of access, and they expect that kind of access. I mean, look at what's happened to shopping malls versus online shopping. Shopping malls are dying, and because the online, you can order it right now. You don't have to get up out of your chair. You don't have to wonder, well, do they have your size, or do they have exactly the shoe you're looking for? You can shop around. So in general, that transition has been made long ago, 10 years, 15 years ago, in consumers, and seeking healthcare has become much more consumer oriented, as I think is appropriate. So we got a long way to go to make ourselves in healthcare as consumer friendly as it is in other parts of your life. And I don't want to trivialize it. I mean, you're not going to die because you bought the wrong set of shoes or it was the wrong size. You might die if you don't get the proper health care, or you might get sicker. So it's a much more complicated dynamic, but I think that's got to be part of what we think about going forward.
I love that. And since you are not afraid to be controversial, especially this point in your life, the argument to socializing healthcare is, look what happens in Canada and look what happens in Great Britain. You have to wait 6 hours or 6 months. And you give an example of trying to find a family physician. Could you wait 6 months? So what's your thoughts on that? Is that the fix, or does that make things messier if we were to come up with a single payer, like a socialized healthcare system like they have all across the world? Is that the solution, or do you think that just makes it worse?
Well, so what I propose in the book, so, what are they going to do? They can't fire me. The book's not coming out till May, and I have a job till the end of June. So what my proposal will make a lot of people angry in the United States because they have a vested interest in different forms of healthcare. But I think that we need a baseline, excellent healthcare system which doesn't have all the bells and whistles, and but everybody has access to it at a reasonable price. And if they want a higher level, so instead of staying at the uh, I hate to mention a motel, but instead of staying at a Motel 6, they want to stay at the Four Seasons. They can pay extra for that. And what I found that was truly amazing, this just knocked my socks off. So as I was doing research for this book, you hear about health systems like Denmark, for example, which is supposedly the best of the best. And they have a terrific national healthcare system. People criticize England, the great UK, they criticize Canada, they criticize many. But it turns out that in Denmark, um, over 40% of the population has also bought private healthcare insurance. It sits on top of their national healthcare insurance and gives them more options. And they don't have to wait for a specialist. And in the national health systems, mostly the wait is for specialists. It's less of a wait for a primary care appointment. So I think we ought to have a blended system like that. People complain, they say, well, that's 2 tiers of healthcare because those who can't afford the private healthcare, they're getting a different level. To which I respond, yeah, well, right now, if they can't afford healthcare, they have no healthcare. And so they're uninsured and they're at a rung that other companies don't have. So a rung meaning in the ladder. So I'm a very strong believer. And I'll tell you the other reason that I'm a strong believer in government-run healthcare. And golly, in today's world, it's getting criticized all the time. It's too expensive and wasteful, and of course that's true. I mean, name for me one industry that's not wasteful. There are none. And I mean, outside of healthcare, you can't name a single one. But I've had a great fortune of I couldn't do it while I've been here, except in a very minimal fashion. But before I came here, I always worked a uh, in a governmental health clinic as part of what I did. So there's a system of clinics called Federally Qualified Health Centers, FQHCs. We have a great FQHC system here in Ann Arbor. There are 3 different clinics. It's called Packard Health. When I was in North Carolina, there's an even larger FQHC system called Piedmont Health. And so I went to one of the Piedmont Health clinics. It was a 45-minute drive from where I worked at UNC hospitals. And I saw cardiology patients, and I was a bridge. Sometimes people would come in who needed a cardiology consultation, and I could tell them, we could do stress tests. I could tell them, well, a stress test will suffice, or no, you need to go to the main hospital. And I could facilitate that. Or oftentimes they'd been at the hospital, they'd had a heart attack, or they'd had surgery, or they'd had a stent, and I could provide their follow-up in that healthcare clinic. And what I learned over these years was that the people who work there, they are so mission focused. And you hear the term medical home, which means you can go to one place and get everything you need. And those FQHCs, they have doctors, they have nurses, they have advanced practice nurses or PAs. They have dental care. They have a pharmacy.
Wow.
You can arrange for, here we helped Packard Health have screening retinal scans that come to our ophthalmologist for evaluation, but they don't have to leave the clinic. So they truly have a medical home. Can we do it right in the United States? Absolutely. Is it going to be like going to a premier health center that has every diagnostic tool, every advanced procedure? No, it's not. But it provides the health care that most of us need. And I will say I do agree with the overall premise currently, which is from the federal government, we need to improve health and prevent people going to hospitals, and not prevent them by putting up a wall, prevent them by making their health such that they can easily access care. They don't need to go to the emergency room, and they're healthier. And for that reason, I think that is the key to making healthcare more affordable in the United States. It's not ratcheting down on how much everything costs. I mean, that expensive technology and all costs money, but it's making people healthier. I'm going to take a little tangent here if I can, um, which is to tell you about obesity and diabetes. So obesity and diabetes is uh, the, comprises almost half of the U.S. population, and it is a true epidemic. And it's something I've seen in my lifetime, and you probably even seen in your lifetime. That's the increase. What's the reason? Lots of reasons. The crummy food that people have access to that is almost, you almost can't put it down. I mean, I have to. I mean, I've had trouble with my weight, and the last thing I need is a bag of Fritos uh, and French onion dip and sitting down to a football game. Like I'll eat the whole thing, and it's just ridiculous. Um, and I know better, but so what can we do about that? I agree. People need to eat more healthily, and we need to provide better food. I agree that people should exercise more, and it doesn't have to be running marathons. I mean, just keeping active and doesn't have to be 10,000 steps a day on your watch. I have a wearable, 3 or 4,000 steps, which is easily achievable. It has been proven to be just as good as 10,000 steps. That was just picked out of the air. But there's one other factor. So these new drugs, which are called GLP drugs, uh, GLP-1 drugs, they are agonists. They activate a receptor system that initially it was thought that they worked by just making food pass through your stomach more slowly. But it's much more complicated than that. It involves neural systems. It involves a system in the forebrain that controls the release of dopamine. And so whatever you do to fight fatigue, if you're drinking coffee, drinking soda, uh, everything that is addictive works through this system. And so these drugs have been proven to not only be highly effective in weight loss and maintenance of weight loss, and incredibly, way more than anything else we have um, or have ever had, but they're also good for other addictive behaviors, for smoking cessation, for alcohol abuse, for drugs, uh, sleep apnea. There's a long list of things that these drugs work
But
for.
they didn't realize that, right, doctor? Because originally, like the Ozempics of the world were a diabetes drug, and then all of a sudden, someone stumbled upon the fact, oh, it actually can help weight loss, and it's exploded. And one of the things about that, and we won't have time to get into like the price of healthcare, but like they're not cheap. These GLP ones.
No.
What can be done with that? Because I know some people have looked into like Medicare won't cover it. So there's issues with people being able to afford it. But again, is this sort of just a band-aid on a bullet hole? Like, because you're like what you go to your earlier point, like would it make people not care about their health? Because if they know, oh, all I gotta do is take this monthly injection, I don't have to worry about it. So tell me about that sort of fine line that we have to navigate through.
Yeah, Joe, that is right on target. So first of all, Medicare used to cover it, and now they're not going to cover it anymore. Um, and many health insurances, Blue Cross Blue Shield of Michigan, just said we're not covering that because we're not convinced it's right, which it is right. I mean, there's no convincing of that, and it doesn't make you lose weight. It makes you not feel like you have to
Yeah.
need junk food or need alcohol or need to smoke. So it's a different mechanism than people think. So they don't lose weight because somehow their metabolism's ramped up. It's because they eat less and they eat less of the wrong kinds of foods because that is an addictive behavior. Um, so what's the right and wrong about that? Well, these do cost in the range of $1,000 per month. And if you don't have coverage, who can afford that? The insurance companies are screaming, saying that's going to make us bankrupt. Medicare doesn't want to cover it anymore because they say that's just too expensive. It's going to increase healthcare costs by tens or hundreds of billions of dollars. So is there an answer? Yes, there's an answer. The answer is the price of those drugs have to come down. It's not that we shouldn't cover them. And I heard this quote from Elon Musk, of all people, who says, these drugs are phenomenal. We ought to just make them affordable. And one thing I comment on in the book, The Great Healthcare Disruption, is that the government has enormous buying capacity, and they could contract with one or another pharmaceutical companies or maybe multiple pharmaceutical companies and say, hey, we will buy $20 billion worth of this drug for this year, or $100 billion worth of this drug. And I believe that the price they could get would make it affordable. And furthermore, maybe the government needs to buy, and Musk said something to that effect. We just need to make these cheap, and everybody ought to take them who needs them. And I don't think it's a Band-Aid. And maybe the government needs to buy a company that produces these drugs. Mark Cuban has his own company for making drugs, and his goal is to make drugs affordable. So, there are lots of potential solutions that I think need to be looked at. Joe, you asked me, is this just a Band-Aid? Are we taking people that have a weak spine and saying, okay, well, we'll put a Band-Aid on that? And I do not believe that's the truth. I think obesity is a disease. I think it's an addictive disease. But let me give you another example. Let's take drugs for high blood pressure, hypertension. FDR, Franklin Roosevelt, had terrible hypertension. There were no drugs available. And if you read about him, he ultimately had a stroke. I mean, I'm amazed he didn't have a stroke earlier. His blood pressure commonly was 250, 260 over 150. And would you say that FDR, it would have been a Band-Aid to give him some antihypertensive drugs? Well, as you said, hell no. And would it be a Band-Aid to take people who have terrible heart failure and put them on drugs that will help their heart failure? No. And I view obesity as exactly the same thing. It's not a Band-Aid. We are what we are. We're in the country we live in. We've evolved from a human genes that years ago, the demand was find food, find food, find food, find food. I mean, they didn't have enough food. And so we all have that genetic predisposition in one way or another. And we're not going to get rid of it. I mean, if you think it's a better idea, I'm not saying you, Joe, if people think it's a better idea to do gene editing and edit out those genes that make you want to find food, I don't think that's a solution. God only knows what other outcomes might result. And can you do that for the 150 Americans who are obese? I don't think so.
Yeah.
But you can use these kinds of drugs, and they're getting better. There are next iterations of them that are even better, have fewer side effects. So I think they're great drugs, and I just think we have to figure out how do we afford it.
It's great. Doc, what's funny is you are sort of very iconoclastic in this, that we are in a world now in 2025 where, like, get the government out of everything. No government. Don't let private sector. The whole thing with the federal government is put it down to the states. Let the counties, let the town. So it is funny that you are coming at it from this angle of the government being involved. And do you think if the government were more involved, maybe with that two-tier system you were discussing, would that help with the, I'm sure you've seen the stats that 60% of bankruptcies are blamed due to, healthcare costs and just, something that put them in the hospital, and then all of a sudden they're bankrupt. Could that put like a really big, like, hammer on that problem as well?
I think you can. And it's all in the balance. If the government were to provide Ritz-Carlton level healthcare, it's going to go bankrupt. The government's going to go bankrupt. And so people have to be willing to accept not having that level of healthcare. But let me just put a different spin on it. I hear about privatization, and privatization works. But, privatization, so it's not spending government money, but it has private companies, for-profit companies have shareholders. You can be sure that the CEOs of those companies are going to be looking out for their shareholders. And for the shareholders to do well, the company has to make a profit. And I get that too. I've had extensive experience in big pharma, and that's just part of it. Now, big pharma, I think, at least my experience was with Eli Lilly. They want to do the right things. They're essentially a medicine company, but they have to be profitable. They can't not be profitable. The government does not have to be profitable. They have to be break even. And clearly, across all the programs in the government, we don't break even on many of them. And it's hard to break even in healthcare. So you got to figure out what that balance is. But I think it's a blend. I think it's a blend of a support that's absolutely needed with other avenues. So take another example. The governor of Michigan, who I like, her mantra when she was elected was fix the roads, and the roads in Michigan are terrible. But that has not happened because there's not been enough money to fix the roads. But would that be less expensive if we privatized making highways? Who knows? I doubt it.
Yeah.
So there should healthcare be different than providing clean water, having roads, having the infrastructure we all depend on, having police officers, firemen. Should that all be privatized? I don't think so. I think that is what we pay taxes for. Now, do I think taxes need to go up? No. So you got to figure out a more economical way to do it. But I think it's a little bit of a false argument, and I'm going to come back to where I started. I think that if you are involved in healthcare and have been involved and continue to be involved at the patient level, you have a whole different view of this than somebody who's an economist or a superb business person, superb at building startups. But I will be slightly critical about many of the startups. Many of the startups that I talked about, the 150, 200 startups in healthcare, the goal of those, yes, there is a goal to improve healthcare. There's also a goal to become wealthy from your startup. And I don't think anybody denies that, but it weighs into this privatization phenomenon that is part of the national argument these days. So I don't think it all ought to be government. I don't agree with people who say, we ought to just totally have this. This has been around forever. When I was, back in 2 jobs ago, when I was in Texas, there was, what was the term then? It was universal health, and universal health died. It was just not a possibility, and it had no political support. And the reason was because of the cost. But we have Medicare, we have Medicaid, we have FQHCs, we have the Indian Health Service. Let's learn what we can learn from those about how to economically provide a level of healthcare that will make us a healthier country. As I said, many, many people will be unhappy with what I propose.
No, it's great. I love it. I love it. I love a little radical candor. His name is Dr. Marschall Runge. The name of the book, The Great Healthcare Disruption, Big Tech, Bold Policy, and the Future of American Medicine. Doc, thank you so much for the time. I really appreciate it.
Thank you, Joe. Great talking with you.
And that's going to do it for this episode. If you want to find out more information about Dr. Runge and our other amazing authors, go to theauthoritycompany.com.